The definition for massive transfusion protocol or massive transfusion within the medical and surgical literature and field is 10 units of whole blood or packed red blood cells in 24 hours. Okay, so this has been studied across various patient populations. I'm talking about trauma, CT surgery, OB patients, liver coagulopathy patients, and the consensus remains the same that it's going to be greater than or equal to 10 units of whole blood or greater than or equal to 10 units of packed red blood cells in the 24-hour time span. A couple other things we need to talk about is this ultramassive transfusion. That is typically seen in trauma patients, although you can see it in a medical population too. That's greater than 20 units in a 24 to 48-hour time period. The critical administration threshold is where it's equal to greater than or equal to 3 units of requiring packed red blood cells within an hour. And then you see that resuscitation intensity score. This you can see in a little bit more of like trauma at VA or Veteran Affairs hospitals. They've studied this, and that's requiring greater than 4 units of packed red blood cells within 30 minutes. Hemorrhage control resuscitation, it has been studied in abdominal aortic aneurysm patients, and basically it's the idea that you want to initiate early plasma and platelet resuscitation as you're undergoing a massive transfusion. And then damage control resuscitation, that is specifically in trauma, and the military will adopt this as well, that you need to consider acidosis in patients who are undergoing a massive transfusion protocol. So now that we've kind of chatted about that, the big thing about this is the massive transfusion protocol, what we've adopted through all this literature, trauma, CT surgery, liver patients, OB patients, is this 1-to-1-to-1 blood component ratio, and that's 1 unit of PRBCs per 1 unit of plasma per 1 unit of platelets. So when do we think about initiating a massive transfusion protocol? So your suspicion should be in specifically trauma patients, surgical patients, and medicine patients. But typically in trauma, we look for somebody that has a systolic blood pressure less than 70 or a systolic blood pressure less than 90 with a heart rate in the 110s, right? Because that's that compensatory tachycardia, cardiac output, stroke volume, all that. Okay, and then you also want to consider a penetrating injury or major fractures when they're rolling into the ER. And then if you see any obvious blood in the body cavities, like on your FAST exam or CT imaging, then you need to consider massive transfusion protocol. Going back to the 1-to-1-to-1 ratio, this is a table that you just kind of break down here, all the different components and how that changes your lab values, okay? One thing I want to mention with this 1-to-1-to-1 massive transfusion protocol is you need to actually avoid crystalloid resuscitation, and that's like primarily from the trauma and surgical guidelines, and that's because if you volume resuscitate these patients with crystalloid fluids, that's going to lead to tissue edema, it's going to delay wound closure, it's going to prolong ventilator days, and it's just going to basically worsen the mortality outcomes for these patients. So from the surgical community, it's definitely a 1-to-1-to-1. And in medicine too, like from the physiological side of things, this 1-to-1-to-1 ratio avoids dilutional coagulopathy. So once you have kind of given the patient all of these blood products, you want to monitor a couple of things, right? You have labs, PT, INR, you want to check fibrinogen, you want to monitor for DIC, like we said, for that dilutional coagulopathy from the medical standpoint. But then you also want to look out for things such as hypomagnesemia, hypocalcemia, and hyperkalemia. That's acidosis that can develop in these patients who are receiving massive transfusion protocols, right? Because you don't want to see these electrolyte derangements, because then that will divulge into a cardiac arrhythmia. So we have to stay on top of these electrolyte abnormalities. If you see anybody with platelets less than 50, you want to give platelets, obviously. If the INR is less than 1.8, you can use FFP as well. If the fibrinogen is low, you can consider giving cryo. But just to run through this little table here, you'll see that for every 1 packed red blood cell we give, your hemoglobin should rise by 1, and the hematocrit should rise by about 3%. One round of platelets should raise your platelets to about 5,000 to 10,000 just after 1 unit. And then you see that the FFP there you should improve your coagulation factors, right? Because you're not just in massive transfusion protocols, you're not just losing like PRBCs, you're losing all blood products. You're losing antithrombin 3, you're losing protein C, protein S. So you need to administer FFP to resolve these coagulation factors. And then cryo, that's typically reserved for low fibrinogen, if you're missing like factor 8, somebody that has underlying von Willebrand 2. Okay, so that's it for massive transfusion protocol. These are just reviewing the blood products. I think this is a great chart. Save it if you need to. I have no problems if you keep it. And I really enjoyed this video, guys. Like and subscribe if you enjoyed this video, if you enjoy my content. It helps me continue to make these videos. And let me know if you have any other suggestions. And thank you guys so much for your time.